Good afternoon, and for us, Happy New Year. Welcome to a very special open classroom, and it's convocation here at the Brown School, so we are extra happy that you are with us today. I'm Janet Gillow, the Director of Professional Development for the Brown School here at Washington University in St. Louis. Most of you probably know the deal with webinars and Zoom by now, but I'll just remind you that we cannot see or hear you. We also cannot call on raised hands, but this is an interactive presentation with time for questions and answers at the end. The chat feature is enabled, and your applause, your questions, your comments are all welcome. We're going to make note of them during the presentation and then also allow time for you to populate it in real time towards the end. I also want to thank and welcome anybody joining us on YouTube. We're not able to moderate chat through YouTube, so just wanted to make you aware of that. So Open Classroom is providing a great window into our school, the scholarship, the just really deep commitment here. Today's program is a wonderful example of that, as well as being a celebration. I want to highlight a couple of things that are coming up in the next few weeks that I think are also just really remarkable examples of the work done here and hopefully the opportunity for you to engage with it. So next Tuesday, that's September 7th, Associate Professor of the Practice Ryan Lindsay is going to be giving a presentation on school-based suicide prevention strategies. And then the following week, Tuesday, September 14th, Executive Vice Chancellor for Civic Affairs and Strategic Planning, Hank Weber, is going to be talking to us about improving the quality of life for residents in neighborhoods with concentrated poverty, talking us through evidence-supported strategies. So I think those programs are going to be really remarkable. Would love to welcome you back, and I'll throw a link in the chat in just a minute for you to join us. But now, not to take up any more of the time and to begin today's program, I'm honored to introduce Mary McKay, who's the Nidor Family and Centene Corporation Dean of the Brown School. Mary.
Thank you, Janet. Thank you for introducing our colleagues, this community, to what you've done under your leadership and your team in terms of Open Classroom. Thank you for really supporting and elevating the work that happens at the Brown School, as well as with our community partners. We're grateful for your leadership for sure. So good afternoon, everyone. It is my privilege to welcome you to the 2021 Brown School Convocation and the Distinguished Faculty Award presentation. So what does convocation mean if this is your first time joining us? It's defined as an assembly of people that come together to meet. And in the Academy, we often think about this meeting as an event that kicks off the academic year. Several years ago, we began the tradition of having our Brown School Distinguished Faculty Awardee give this convocation speech. So Dr. Leo, that's you. And I am really happy to tell you a little bit about our colleague and the accomplishments and why I'm really looking forward to your remarks. So it's my pleasure to introduce our speaker today, Dr. Leo Cabassa. Leo, you hold a number of positions here at Washington University, and I cannot spend the time naming all of them, but I'll highlight a couple. First, you're a full professor at the Brown School and one of our esteemed faculty colleagues within the school. You direct our PhD program in social work, and you and others have brought an amazingly talented, diverse cohort of the next generation of social work scholars to our school. You also co-direct with Byron Powell, the Center for Mental Health Services Research. That center has a long, meaningful, rich tradition within our field, and really was the pride of our colleague, Dr. Enola Proctor, who I know you work with very closely on our doctoral and postdoctoral training programs as well. So Leo, you know that you're going to present your research on examining some of the physical and mental health disparities, particularly among racial and ethnic minorities with serious mental illness. And you're going to focus on improving health and mental health care for underserved communities. The title of your talk, A Call to Action, Addressing Racial and Ethnic Health Inequities in People with Serious Mental Illness, I think really will be a summary of the amazing work that you are focused on, as well as your colleagues. Leo, we know you as a dedicated faculty member, a passionate teacher, just a highly qualified, focused, and capable researcher, really an expert in our field. You're also just an excellent colleague. And I think that that's going to come through as the good human being you are as we hear you talk about your research. So it is my privilege to hear your remarks at convocation. But first, I need to emphasize that you have been selected as the recipient of the 2021 Brown School Distinguished Faculty Award. And it's a big deal. Many of your faculty colleagues who have received that award before you, I see on the list of participants. What's also even something that kind of isn't necessarily stated in my remarks is you are also a Brown School alum. And so full circle from being an alum to really being a faculty leader to receiving this award today, I want to just extend my congratulations. Please, anyone that's near their chat function, please extend a hearty congratulations to Leo, a virtual round of applause. And Leo, we're so looking forward to
Thank you.
and thanks for showing the award and for the Dean's team that really facilitated you making sure that you had that award in your virtual environment. So with that, Leo, take it away. We're looking forward to your remarks.
Definitely. Thank you so much, Mary. Let me set this up so we can share what we want to share today. And Jana, are we seeing the slides?
In an edit mode.
Okay.
You'll want to put it on slideshow.
And we're making it slideshow now.
Beautiful.
Slideshow? Janet, do we have it in slideshow?
It
Yes,
is beautiful.
perfect.
Perfect. So, Mary and colleagues, thank you so much for this opportunity. I'm super excited to be doing this and to provide this important start to our semester and our academic year, and so honored to be provide this opportunity to talk to you about the work that myself and my team have been doing. And I want to start with some basics. So thank you for the people who have supported this work over the years. And first and foremost is to thank my family. These are the people who provide all the support that I need to provide the work that we do. And I work every day to make you proud for what we have here. And we're including our dog. We always forget our dog. And we're including our dog in our family here. But some of you are out in the audience, and I'm super excited to be sharing this with you. I'm also here because of my mentors and collaborators, as Mary has mentioned. These are people who have really helped me throughout my entire career, and I'm here because of them and all the great inspiration and examples of doing not only good work, but good science and science that matters to people's lives. So I'm deeply grateful for all the opportunities and everything that I've been doing. It's because of the work that they have provided. And last but not least, I do want to sort of thank my team. I'm presenting here part of my work, but this is really a team effort. Disparities work and implementation science is a team sport. We play different positions, and I'm super excited to be able to present this work that our great team has done over the years in improving the physical health of people with serious mental illness. So this is a testament to the hard work of this group and this incredible dedicated group. And I'm dedicating actually this talk to a colleague of mine that passed away several years ago, Kelly Adams, who's a champion for improving the physical health of people with serious mental illness. And her passion and her dedication for this work is a true inspiration to what we're going to be talking about today. So let's get started. So, we are living through unprecedented times. COVID-19 continues to impact millions of people around the globe. The uprising for racial and social justice, ignited by decades of structural racism, injustices, and the murders of George Floyd, Breonna Taylor, and countless others, que en paz descansen, at the hand of police officers in the US, have pulled back the curtains and clearly revealed the deep social, economic, political, and health inequities that have taken root in our society and directly impact our everyday lives. Over the past decade, my team and I have focused on addressing health inequities in minoritized and historically marginalized communities living and recovering from serious mental illnesses like schizophrenia and bipolar disorder. And I'm sharing here something that is at the heart of what we do. To reduce these inequities requires that we engage with our community. And this is a quote from a seminal project, a seminal report that highlights the needs that we're going to be talking about. And that last sentence is something that I want to highlight throughout the entire presentation, that at the end of the day, no matter what work we do, what strategies we use, our principal partnerships must be with the people we serve. So the goal of my presentation today is to illustrate how our team is trying to put this principle into action by presenting 4 critical areas that we hope can begin to address these health inequities. And for each area, you're going to hear stories of people that embody the challenges of living and coping and surviving these inequities, and how these stories have informed not only our work, but also our science. These stories come from composite of different people, and I use different fictitious names and alter personal details to protect people's identity. And this is part of a book project that I've been working over the past 2.5 years. So you're gonna get to see something that's it's still in press, but hopefully will give you an idea of the work that we do. So let's start with one basic story. And I want you to start thinking of meeting Carla. I first met Carla many years ago as part of a project that we were conducting in New York City to examine the physical health experiences of Latinos with serious mental illness, basically how they sought help for this condition, what type of care they received. Carla was born in the Dominican Republic. She had lived most of her life in New York City. She spoke English and Spanish, and she was in her mid-40s when we met. And one of the major questions that we had in this discussion was to describe Carla's health. And this is what she told us. I'm sick from head to toe. I have many problems. I have diabetes, high blood pressure. My mind is not right. And I also have really bad arthritis, and I had for a long time. Carla was someone who was connected to primary care. She went to the doctor, but she always seemed disenchanted with the care that she was being provided. She felt like every time she went to the doctors were always rushed and overburdened. She never felt like she had enough time to talk to her medical providers about the questions and her treatment. And she worried about the medications that she was taking, particularly those medications for psychiatric disorder. Carla had a schizoaffective disorder that she was recovering from. And she knew those medications were bad for her diabetes and her hypertension, but she received very little guidance and support to addressing these issues. And Carla, in many ways, felt like she had the healthcare system had not provided the care that she needed, and she passed away about a year after our project. Carla's description exemplify for many of us the people who were studying. These are people with serious mental illness. There's around 10 million adults in the United States that report a serious mental illness, such as schizophrenia or bipolar disorder. These are highly disabling conditions. 5 out of 10 of the leading causes of disability worldwide are serious mental illness. But yet recovery is possible. With the right support, with the right treatment, we can help people recover from this disorder, to cope with them, and to live fulfillment lives. So part of our work is to really help people recover from this disorder. However, people with serious mental illness like Carla also have a major issue regarding their physical health. They're dying 13 to 30 years earlier, largely due to preventable diseases like cardiovascular disease. And people like Carla not only have a serious mental illness, but they're also part of a minoritized racial and ethnic group, in this case, a Dominican woman. And we know that there's a double health burden of being a minoritized racial and ethnic minority and having a serious mental illness that increases your risk for multiple negative health conditions. And with the COVID-19 pandemic that we're going through, plus everything that's happening in our world, there is a serious issue happening right now that we need to pay close attention to help people like Carla recover from their diseases and actually be able to survive. But there are major critical gaps in the science in how do we address these inequities. And one of the major gaps that we see is a underrepresentation. Here you see 3 systematic literature reviews that our team has conducted over the years. In fact, the last one is from one of our great doctoral students, Mark Hayes, who just published this systematic review examining health interventions, particularly smoking cessation interventions for people with serious mental illness. And one of the things that you see throughout this literature is a stark underrepresentation of racial and ethnic minoritized groups in these intervention trials. As we've discussed in previous publication, the exclusion of historically underserved communities in clinical trial creates a serious blind spot, not only in our treatment science, but in moving that science into practice. We need to develop the evidence to make sure that these interventions work with the population that most need it. So they're responsive to their needs and their preferences. And this is a serious aspect that our team is really trying to address by creating studies that are grounded on the realities of people with serious mental illness from racial and ethnic minority groups, and include them in our studies and in how we conduct our science. A second major gap has to do with a serious silence that we're seeing in inattention in this literature around culture and social determinants of health are often ignored in this literature that's focused on the physical health of people with serious mental illness. Culture and social determinants of health, as we know, matter, and they matter enormously. They shape our health behaviors, they shape our experiences with illness, they shape the interaction we have with our providers, they shape the interaction that we have with our healthcare system. So we need to make sure that we are talking and including attention to cultural issues as well as social determinants of health issues as we're developing the science. And that's a major other area that our work is trying to do. So we're addressing this gap in multiple ways, and hopefully we can illustrate today how we're doing that. We're incorporating culture into our interventions, engaging large numbers of racial and ethnically minoritized population, and expanding the reach of the intervention so they reach people like Carla in their communities where they live. So when we examine as a social worker, one of the things that really drive the work that we're doing, we're trying not only to study these issues, but actually to intervene, to help with all of these components. So we're always looking for modifiable risk factors that can be the targets of our interventions to improve these inequities. There's a constellation of factors, as you can see here. This is some of the factors that you can see. And I'm going to start with medical care, which is one of the first studies we did in this area and how we address this issue. So one of the critical areas, this is a quote from one of our administrators in a public outpatient mental health clinic that really captures this dilemma that we're facing, that people with serious mental illness and also from racial and ethnic minority have to navigate between the healthcare system and the mental health system. They have to go through this maze. And it is overwhelming for patients without the appropriate support and coordination. And people do get lost in the system, and they don't receive the care that they need. So part of the work that we're doing is trying to address this issue and trying to break and help someone navigate through this maze and create a better access to care. So our first call to action has to do with integrated models of care that bring physical and mental health together should be the norm and not the exception. That should be the way that people receive care, being able to access both mental health and physical health in the same locations. And there are many different models out there that have been tested to address this issue. And we have contributed to this literature by developing a healthcare manager intervention. In their most basic form, healthcare managers, basically, as you can see, they serve as a bridge between the patient, the primary care physician, the mental health provider, creating partnership with all of them and ensuring that the client's health issues are being properly identified, evaluated, treated, monitored, and managed, and engaging the client and their support system in this process. And this is an intervention that we adapted from an existing intervention that was developed for Black individuals in Atlanta, Georgia, and we adapted it to Latinos, such as like Carla, and we were doing. To do that adaptation, one of the things as an implementation scientist, we're always concerned about making sure that the interventions that we have fit with the reality of a practice. And following that goal that I started with in the initial part of this presentation, that our principal partnership must be with the people we serve. This is an approach that we develop on how to take an intervention and adapt it with community input, with community wisdom, and bring the expertise of the community and these researchers together so that we can adapt intervention with the community to address their needs, their preferences, and using the assets in that community. So this is an approach that we use. I'm happy to answer any questions people may have about this process, but it's one of the approaches that we have been using to really ground our interventions in the realities in which people live with our stakeholders. And what happens when you do that is that you identify a series of and levels of adaptations that are critical to make sure that the intervention fits with the reality of practice. And so here's some examples of the type of adaptation that we did, not only for the client, but for the providers. A part of the magic of our adaptation is that we took an intervention that was used for registered nurses and we adapted it for social workers. Master level social workers could deliver and be effective healthcare managers. And in our pilot study that we conducted in an outpatient mental health clinic in New York City, we basically tested this intervention. It's a 12-month intervention. Clients meet at least monthly with their healthcare manager, and they work on specific health issues that they have. And the idea is to connect them to primary care and coordinate that care between primary care and mental health. So we did this 12-month pre-post one group design. We collected information at baseline, 6 and 12 months. And then we conducted 3 post-intervention focus groups to really get a sense of the client's experiences with this intervention. And these are all Latino clients with serious mental illness and at risk for cardiovascular disease. And what we found was that it is feasible to deliver this intervention by social workers with the right support and the right supervision. We found that patients really like this. They engage with the intervention. 85% of our participants in this 12-month intervention not only completed the study, but completed the actual intervention. They went to their visits. And one of the things that we found from our qualitative data is that participants, because of the way that we have trained healthcare managers to be culturally appropriate, to connect with the lives of their clients, we found that participants formed deep personal connection with their healthcare. They felt that their healthcare manager treated them with respeto, with cariño, affection, and with confianza, with trust. And here's a quote that really exemplifies one of our clients, one of our participants' views of their healthcare manager. She treated me like I was family. She talked to me with such humility. She was very open, and I thank God every day that I had her for a year. So that deep connection was extremely important for our participants to feel that they have someone that they can rely on for their healthcare. And what we saw is that bridges to better health and wellness, in fact, increase patients' activation, so engagement in their own healthcare. And most importantly, it almost doubled the rate of preventive primary care that people receive over the course of the year. However, one of the things that happen with science that when we do this type of studies that we identify other needs that are happening. And one of the findings in the study is that even though we connected people well to care and to primary care, their health didn't improve. So that got us thinking about what else can we do? We can connect people to care, we can help them navigate that maze, but we also need to think about what's happening outside of the clinic, what's happening with their health behavior. These are people that have diabetes, have chronic diseases. So what can we do to help in that aspect? And the second call for action is to move beyond the clinic walls, that we need to start thinking and delivering interventions beyond that, what happens in outpatient mental health clinics or in primary care clinics, and try to bring interventions out into the community. People live in the community, people work in the community, people are out there. So how can we bring interventions and our best science there? And that's sort of the impetus of our next level of our work that we're doing. And one important setting for people with serious mental illness is supportive housing. This is where people live. This is a growing service sector for people with serious mental illness that provides apartments, either in congregate settings or apartments throughout the community. And they also provide, alongside the housing, health, mental health, and social services. So we, when we began this work, we partnered with supportive housing agencies to really understand and get a sense of the realities of the settings and how can we bring interventions to those settings. And following the principle of partnership with the people that we serve, we started this journey not as experts saying, here's the intervention that we can integrate into a setting. We actually started from the ground up. We asked clients about their particular needs. We wanted to engage clients in a dialogue about their physical health and their wellness. So we use this participatory methodology called Photovoice, which is a participatory action research approach that entrusts people with camera to document their everyday lives and then inform social action. This methodology is intended to enable us to see, to hear, to understand how people make sense and meaning of what matters most to them. It relies on photography as well as the stories behind that photography, enabling people's visions and voices to surface in order to inform social action. So this methodology gave us an opportunity to really examine and learn from the experiences of these participants. And what we learned is that Photovoice generated really important information about what type of interventions we can deliver in supportive housing. They wanted interventions that were peer-based. Basically, don't bring professionals here. Don't tell professionals to lecture to us. Bring peer specialists, bring people who have recovered from serious mental illness, who are recovering from a chronic medical illness, who can then teach us how to address this, that people who have walked the walk and talked the talk, people who have experiences, lived experiences with this in the community. So that helped us identify that whoever we deliver this intervention needed to be a peer specialist. We also examined the content. People wanted things about weight loss, about physical activity, and how do you do that in your community? Not about raising the knowledge of these issues, but actually raising people's skills and learning how to do it where they live and where they interact day to day. So we took that idea and we ran with it. We looked for a healthy lifestyle intervention that had been tested in the general population, the group lifestyle balance, which actually is adapted from the diabetes prevention program, a highly effective intervention to prevent diabetes and actually being used to help people with diabetes and people who are at risk for diabetes to reduce their weight. And we adapted it for the population as well as for supportive housing. And then we tested it in a hybrid type 1 trial as a major study to test the effectiveness as well as the implementation of the intervention. And this project called Peer-Led Healthy Lifestyle Program in Supportive Housing is actually a hybrid type 1 design. And the reason I want to highlight that here is because this design it's a rigorous way of testing not only the effectiveness, does the intervention work, but also provides us an opportunity to examine how is this intervention being integrated and implemented in the settings in which we're testing it. So it gives us an opportunity to learn something extra than what you get in an effectiveness trial, to really get into, is this actually working in the context in which we're embedding this intervention? Our intervention is an extensive intervention. It's a 12-month intervention, 22 sessions delivered by a peer specialist, focuses on diet and exercise. This is a major commitment for people to engage with. We did this in 3 supportive housing agencies, 2 in Philadelphia, 1 in New York City, and we recruited 314 participants across this setting. These are all people with serious mental illness and who are overweight and obese with a BMI of 25 or above. And following the principle from our work, the great majority of our participants, 82% of participants are from racial and ethnic minority status, mostly Black. And then we measure the main outcome. And our main outcome was a pretty high outcome. It was the people achieved clinically significant weight loss. That's 5% weight loss from your baseline weight at the end of our trial. And there are many findings from this, and I'm just going to focus on a couple of them as we move forward because of the sake of time. So you do this great study, and what we found was we had actually no findings. Compared to usual care, our intervention did a little bit better than in achieving clinical significant weight loss compared to usual care. However, those differences were not statistically significant. However, PGLB results, what we achieve in this trial, are comparable to other healthy lifestyle interventions for people with SMI, which have been tested with clinicians and experts, not with peer specialists. So we now have developed another set of intervention that can be used with peer specialists, and they can deliver it with fidelity and actually help people with serious mental illness, majority of them in this case Black, to actually achieve clinical significant weight loss. So our findings are comparable to what's out there in the literature, and that provides another set of interventions that can be used for this population. But as I mentioned, this is a hybrid trial, so we also learn an enormous amount about the value of having peer specialists deliver this intervention. What we found here was that they are critically to engage and motivate people in healthy lifestyle changes. And this is a great study from one of our postdocs, Lauren Bochicho, who's at Columbia University School of Nursing, and Anna Stefanchik, one of my great collaborators, that really got into understanding what is the added value that peer specialists bring to this intervention. What you can see here is that it provided not only experiences with serious mental illness, but sharing the experience of living and surviving with a chronic medical illness and making healthy lifestyle changes. And the peer specialist could not only provide information, but actually provide examples, support, encouragement, motivation to address those major issues. There's multiple papers that have come out of this, and it's really showing that the value added of having peer specialists deliver this type of care, and they are a valuable workforce to address these inequities. And we continue to work in this area for that purpose. So up to this point, we have done an intervention within the clinics. We have done interventions outside of the clinic. We have looked at people who have already risk factors for chronic diseases. But what about prevention? One of the things that was very striking in the work that we've been doing is that many of our participants already have a chronic medical illness. Their health is already compromised. So what about trying to prevent someone from actually developing a chronic medical illness? Can we intervene much earlier? And I want to highlight this point by presenting a dilemma that we learned from Enrique. Enrique was one of our participants. He's an he described himself as Afro-Caribbean. His mom is was Black. His dad was from Puerto Rico. And he was diagnosed with schizophrenia in his early 20s. He's in the mid 20s when we met with him. And this is how he described taking psychiatric medication. It cures you in one way, it damages you in another. He knew that this medication that he was taking antipsychotic medication for his schizophrenia, was helping him with the voices in his head and keeping him outside of the hospital. But in the other side, he was gaining an enormous amount of weight, and he was deeply concerned about what that was doing to his own body. So people with serious mental illness, a person with SMI taking antipsychotic medication should not have to live a lifetime of physical illness in order to achieve good mental health. We shouldn't be putting people in this dilemma. A medication that helps for one thing may actually be damaging you in another. So what can we provide Enrique to prevent this from happening? And so what we're at right now is really, and this is work in progress being led by Ana Stefancic from Columbia University in partnership with us. We're trying to develop an intervention that brings this work together, both medical care and health behavior. And our call for action here is not just to screen and monitor, but to intervene from the very beginning. Health promotion from the very beginning. The moment someone gets a diagnosis of a serious mental illness, exposure to an antipsychotic medication, they should also be getting a healthy lifestyle intervention. They also be getting healthcare and connecting to that. And the literature supports this idea. Early psychosis or emerging SMI is a critical period for addressing this cardiometabolic risk. 50 to 80% of young people with psychosis or emerging SMI gain 7% of their weight loss in their first year if they're exposed to antipsychotic medications. This is serious. So what can we do to address these issues? Also, another health risk factor is tobacco use in this population is very high. So we need to bring interventions into earlier on. And we're partnering with our great partners in New York City, in New York State, who are doing coordinated specialty care for first episode psychosis. There are 260 clinics across the United States in 49 states that are delivering this care for people with first episode psychosis. It's a multidisciplinary team. It emphasizes people's needs. And what we have here is a good platform to see if we can integrate a health promotion program here. And that's where we're going. What's needed and what Ana Stefancic and our team is doing is really with community input, with stakeholder input, beginning to develop a multi-level health intervention that can be embedded in coordinated specialty care that focuses on care coordination and monitoring, but also is working individually with that young person to learn about healthy lifestyle, to get access to free tobacco smoking cessation program, and to work with peers, another person that can help them to provide them a model and make this attractive for these individuals. And we're in the process right now, literally writing a grant to get this idea out there and to be able to test it. And our partners in New York, Lisa Dixon and the rest of On Track New York have been incredible partners and willing for us to work with this and test this idea out with the input of the young people participating in these interventions and in these programs. But up to this point, we've talked about three things, but we've left something, and we haven't talked about the elephant in the room. And this is something that's really important for some of the work that we continue to do. And that elephant in the room is at community level factors. those factors such as stigma, such as poverty and racism. And for this talk, I'm going to be focusing stigma in particular. That stigma is a major and a fundamental cause of inequality that we need to address, particularly when people have a serious mental illness, a highly stigmatized identity that needs to be addressed. None of these interventions can be supported without addressing stigma. And stigma has always been present in the work that we've been doing in physical health. Most people think about stigma preventing someone from identifying a mental disorder, from seeking help. But stigma is more, permeates more, and it's more destructive in people's lives than what we think. Here's an example of Marcos. He's a Puerto Rican male with schizophrenia and diabetes, that when we asked him to tell us about a negative experience seeking physical health, this is what he came up with. This is what he related to. One time in the hospital, my stomach hurt. I keep telling them, but they just gave me a Tylenol. I ended up passing out. It was my appendix. They just didn't believe me. And this is a classic example of what we call diagnostic overshadowing. This is where, in other words, a psychiatric disorder overshadows the patient's physical health complaints, leading to misdiagnosis, as well as not receiving the medical care that they need. And this is a serious issue that is happening. And so stigmatization, as I mentioned, is a fundamental cause of inequities. And if you can see here, it permeates the entire healthcare system, from patient factors to client clinician encounters, provider factors, and then the healthcare factor. Lack of investments in improving our public mental health system. A lot of that has to do with our stigma towards this issue. So the work that we're doing in this area is really trying to address this call to action, that we need to crush stigma at all levels in order to move this agenda forward, through advocacy, through education, through research, and through contact-based intervention. To crush stigma, we not only need to change people's mind, but we also need to change people's heart. We need to appeal to their emotions, and to bring the stories of people recovering, of people surviving, of people thriving, and being able to overcome their mental illness and their chronic medical condition to the forefront, that this and humanize that experience so people don't stigmatize them. And interesting enough, this work in stigma actually started here during my time as a doctoral student, that it planted the seed of how can we address stigma, and mental health literacy was another piece for that in the Latinx community. And this is an ongoing initiative that we have right now in this field. We're studying and disseminating what you see here are depression photonovelas, secret feelings, sentimientos secretos, which is an entertainment education approach. The idea here is to entertain you as well as educate you. And this photonovela has been tested in multiple randomized controlled trials that improves mental health literacy and reduces stigma, overall levels of stigma in the Latinx community. More recently, in partnership with one of our great doctoral students and T32 fellow, Nancy Perez Flores, and with support and shout out to Washington University Center for the Study of Race, Ethnicity, and Equity, we developed a new innovation lab called the Latinx Collaborative to reduce stigma and improve mental health literacy. And this is where we're bringing this work together to figure out how to move it forward, how to create better tools for the Latinx community. And we're in beginning stages of conversation with Casa de Salud to begin to think about how can we embed some of this anti-stigma work into the work that they're doing. And we're also bringing thought leaders throughout the United States that are deeply concerned about this issue and doing incredible work in this area to come and talk to us, to share their knowledge, to share their expertise. And then lastly, we're beginning a great collaboration with Dr. Elliot Rivera from Ponce Health University, Ponce Health Science University, where he's actually developing a module that can be embedded in our Bridges to Better Health and Wellness intervention to address this issue of diagnostic overshadowing and the stigmatization that happen from healthcare providers. So in the end, what we have is a call for action for 4 major areas. Integrated models should be the norm, moving intervention out of the clinics, not just screen and monitor, but intervene from the very beginning and cross stigma. And as I think through, and as I have been putting this talk together, I was trying to find a good way of where do we need to go, and how can we encapsulate everything that we have talked about today. And actually, this quote came from one of our great colleagues, Vera Thompson, great colleague from the Brown School, someone who I deeply admire for her dedication and her work eliminating health inequities, which I think encapsulates where all of this work needs to go as we're moving for action. The time for action is now, and to achieve equity, we must be willing to intervene directly on the social determinants and the practices and policies that sustain the system of inequality. That's the way I think that our field needs to move forward, science needs to move forward, and that social work and public health can address this issue by really intervening directly on the social determinants. So thank you for the opportunity to share our work and all the great work that we have done, and I look forward to your questions.
Leo, thank you. Thank you so much. I'll let you take a breath because I know what that can be like to talk for consecutive minutes. So I'm going to encourage our colleagues in the audience to please send in a question for Leo. I'll ask the first one that came to me directly, and that had to do with the really high rate of completion in the intervention program that you presented, and how were you able to support, people staying with a really pretty significant time commitment, multiple contacts, navigating the obstacles that often interfere with program attendance. So could you talk us through some of that and get us started? And please, audience, colleagues, please put a question or two in the chat so I can ask Leo.
Definitely. No, so I think there's a couple of things, and I didn't do anything. This is not what I did. It's the people who we work with. So I think there were two things that I think really highlighted the high engagement. One, we were addressing a major need that the social workers, in a sense, were already dealing with, which is the physical health of their clients. So we provided an intervention that provides some system and some approaches that the social workers could use to help clients. And many of the social workers were already doing this, but we provided something and we built this intervention with them in mind. From the client side, I think that quote captures the deep connection that clients make with the healthcare manager, that this was not only someone who just advocates for care, that just connects you, someone actually who cares for them. And to tell the truth, one of the two things that I think we did in that intervention that helped, one was add a cultural assessment called the cultural formulation interview as a beginning assessment that asks clients, what do you think about your physical health? What worries you about? It gives them an opportunity to tell their stories that no other physical health provider had done. Very few, all of these people had a chronic medical illness. Nobody had talked to them about or asked them, what do you fear most about your diabetes? What have you done? So that gave an opportunity for clients to feel like they're being heard. And it also conveys a really critical cultural aspect of personalismo, that this physician, this healthcare manager, in a sense, cares for me and cares for me in a personal way. So I think that connection was really important. And then the great care managers that we had that really went the extra mile to do this work for free. We were not paying anyone to do this. This is extra work. But they did, and they connected. And I think that helped address. And also clients began to feel better, feel like they have someone in their corner so they can navigate this maze with someone that can advocate for them, which is really important. And they hadn't had that before.
So I have a couple of other questions coming in. So please, colleagues in the audience, keep these coming towards Leo. But one of our audience members is particularly interested in this notion of diagnostic overshadowing. And do you have ideas about medical training, nursing training? And I think it's important for us, social work and public health training, to really be able to spot this, identify it, interrupt it, dismantle it. And so your thoughts about that particular issue, Leo? For
sure. And we heard this over and over again from our Latino clients, and the diagnostic overshadowing happening not only for serious mental illness, but for being an immigrant, for speaking Spanish, and or even to be able to communicate. So from the provider side of things, this is stigmatization that is happening from providers. So first, The healthcare manager can help with this by advocating for that care, by clarifying the clinical picture that happens in an interaction in an emergency room that is very quick. Sharing information. One of the things that we did from in our healthcare manager is that we gave people personal health records, and it's literally a little booklet that tells them exactly all the health conditions that they have, the medications that they're taking, and they can share that with a new clinician and to see that what the person has. And then Dr. Rivera's work in Puerto Rico is really tackling this by training primary care physicians and nurses on how to spot this type of stigmatization. He's using videos and testimonials to train people on how to communicate around physical health issues and provide input into that. So there's ways that we can do, because stigmatization happens in the community, stigmatization happens from providers as well. And this is not to blame providers from this. Providers are trying to do the best that they can with the limited amount of time that they have. So any tools that we can provide to clarify the clinical picture, I think it helps in that sense. And this happens a lot because of mental illness and other things as well. So I hope that.
Correct. Incredibly important concept. So I'm going to combine two questions that kind of focus in on the peer specialists. So one comment and question is, how are the peer specialists trained? There is a dedicated training program here in Missouri to certify the peer specialists. And so if you comment on the training, and also Carolyn asked some really important questions around sustainability, opportunities for these to actually peer specialists to be compensated with or without a kind of a research program. So opportunities that you see related to peer specialists, and I'll take a look at some of the other questions. And
for sure. So I'll tackle that one first. We were just reading something right before this presentation. So in some places, peer specialists are now being able to charge for Medicaid as part of the workforce. So that's one way that it's being sustained. This workforce is being sustained. That is a billable service in some mental health settings. And that's, I think, a really important one. And that number continues to grow every year. I think the highest we've seen right now is 40 states have some reimbursable components for that. In terms of the training part, actually for our project, what we did, each New York and Pennsylvania both have certification processes for peer specialists. So we actually hire people who were already certified or in the process of being certified through that training. And then on top of that, we train them on our intervention. So they received the same training that everyone receives for this intervention, which is a 2 days massive intervention, a training that leaves you too confused at the end of that. But then what we did is that we took the next couple of months and actually walk the peer specialist through the intervention and have them actually do things of the intervention on themselves. Like, go ahead and track your eating for a day. Go ahead and track your steps for a week. Learn how to read labels. See how you can shop more healthy with limited amount of money in your community. So we gave them that lived experience in the training, and then they modeled that for us. They actually had to do some mock sessions with us, and we provided training. Then what we did, we supervised them, and that was another element, not only the training, but the supervision of the peer specialist throughout this intervention was really important, where we supervise them in terms of how to deliver this care better, but also how to not lose themselves in this. One of the things that happened in our team is that peer specialists began to deliver the intervention as manualized, and you're like, oh my God, you're losing the peer element. You need to bring your lived experiences to that. So how to balance that? And there's some great papers we've published on what we learn about training and supervision to do this. And incredibly enough, we also, another major component, we pay them a competitive salary in their marketplace. And that was critically important because we value this work. This is employment for this individual. So we make sure that we were providing a good competitive salary in the markets in which we're working at.
So, Leah, I'm going to stay on peer specialists for one more minute, and then I'm going to move on a little bit to outcomes. So although my assessment of the literature is that we've been testing the important impact of peer specialists for quite some time now. That's how the 40 states came to be able to incorporate this expanded set of workers into billing. But I think there remains some questions maybe connected to stigma around how to hire, how to train, how to integrate peer specialists into your systems. And I wonder if you have some best practices where even in the face of peer specialists being able to bill, there's still some resistance in kind of business as usual medical or clinical care, and ways that your team worked with that would be, I think, really helpful to this particular audience participant.
Oh, for sure. And I wish I could share, we have a paper that Ana Stefanczyk led on exactly this topic of supervision and training and supporting. And part of this is actually, as you mentioned, Mary, very critical. It's not only about training the peer specialists to deliver this care, but training the staff on how to work with a peer specialist, a clinician, a social worker, a psychiatrist, to now incorporate this person into the team, that this is a valuable person. And as we were doing this study, we actually had thought a little bit about that, but we didn't, it really caught us by surprise. Like these agencies who really wanted to do peer specialists and wanted to integrate them, we had to do a lot of work with them. We had to train them on how to interact with the peer specialist, how to integrate them into their team. And that was an ongoing process. And we're creating the spaces for the clinician and the peer specialist to come together and to value each other and value each other's expertise and wisdom and helping them. And one of the things that happened was that clients started to get better. Clients started to engage better. And clinicians were like, well, the peer specialist is really doing something that we are not doing. So that was a very important element. We could have done more of that. Actually, we do this study again. That was one of the major aspects that we need to do, how to work with the clinical staff, the professional clinical staff, on how to integrate and work with peer specialists. Another strategy was to train them together and to supervise them together. So we need to learn how to provide clinicians a way of how to supervise peer specialists, how to work with them and integrate them. And there are multiple things to do there, but that's a major element that you see here. And the last thing is to clarify the role. Peer specialists come into this role and they're very ambiguous. And in our project, they had a very clear role: deliver this manualized healthy lifestyle intervention. That helped enormously to say, this is the space that the peer specialist is going to work with. And the clinicians knowing exactly, okay, that's what this person is doing. That was really important to address these issues. Yeah.
Beautiful. And one of our audience members made a really important point that I just want to say out loud. You know, that the peer specialist is meant to be integrated as a full member of the team, and also to not make the assumption that also because you have a lived experience with mental illness, you become a peer specialist, that you don't also have professional skills. Right. That the peer specialists come of backgrounds, expertise, educational backgrounds. And so one of our audience members are just wanting to make sure that we contribute that as well.
Exactly. Definitely. Yeah.
Okay. This may be the last one, because this is a little complicated one. This relates to some of your findings. Mm-hmm. And this is an ongoing, program of research, but it's confusing when you have such a terrific engagement finding and then the outcomes don't follow. I've had some of these findings as well. Yep. And so that led us to a whole other set of research questions around what needed to be in the service package to actually drive those outcomes. But can you talk a little bit about that? Because I think it's, I can see a couple doctoral students on here, and the notion being that you can have a positive finding in one direction and not find what you expected in another set of domains.
That's right. Well, and in many ways, this is science. We do this, we have to do this trial with equipoise, making sure if we knew the answer, we wouldn't do the study. So that's one element of this, that it is really, this is a discovery, an important one. One of the things that happened in this trial, and this is a methodological for the doctoral students in the audience, this is a methodological issue. We did a randomized control trial where we randomized people within the clinics. So within the clinic, you have a certain group of clients receiving our intervention and another group of clients who are not receiving the intervention. but these clients are interacting with each other. These clients are talking to each other. They're living in the same apartment buildings. And one of the things that was really troublesome in the terms of science, but actually very good as a social worker, everyone improved over the course of this trial. There was a real improvement of weight loss and clinically significant weight loss on both dimensions. And when we asked people, where were they doing the intervention, we were seeing people in the usual care actually doing parts of the intervention that they were supposed not to do. So there was some diffusion of this intervention happening already within the sites. So a methodological improvement of this was to do a cluster randomized trial and randomize at the site level instead of at the individual level to address this issue of contamination, if you want to say. But you see, contamination that is improving people's lives and health, go ahead. If our science can do that, please do so, because it's helping us. The other major component, we were doing this while the ACA was being implemented in New York, where there's things happening in Pennsylvania. So this agency, the issue of healthcare for people with serious mental illness was in the air, and our context of practice shifted throughout the trial. We couldn't control that. We didn't want to control that. So the agencies also started to do things to improve their usual care. In fact, one of the agencies ended up having a SAMHSA grant to integrate care there, a primary care clinic within their supportive housing agency. Awesome. We want that to happen, but it impacted our findings in this sense. So it's the messiness of this work, and to have the right method to learn from that messiness.
Well, I think our doctoral students will appreciate why you look at those threats to research designs. And I think I might have been one of your threats, Leo, because at the time, I think I was implementing wellness self-management all across New York State. They had a lot of overlap with the intervention that we're trying to implement. Yeah. So Leo, we have come to the end of our hour. I want to extend our extreme gratitude for you sharing your work, congratulate you on being an awardee, and really just thank you on behalf of the Brown School for being a terrific inspiration to all of us. So please join me in thanking our speaker. Welcome to the 2021 academic year. And I hope that we've set you on a very good track for the first week of the school year. Congratulations. Thank you.
Thank you, Mary. Thank you, everyone.
Thank you.